Welcome to another episode of Health Matters with PA Lynn Szabo. I'm Heather, and what are we going to talk about today, Lynn?
We're going to revisit telehealth because it's kind of a setup for our next visit, and we're going to be talking to an actual telehealth provider that's really helped Del Norte, and I want to bring his talents forward. But telehealth is defined as the use of electronic information to support healthcare, and then telemedicine is a subset in which the use of medical information is made available during a remote clinical service. Now, having said that, I'm going to mix those two words up because that's kind of meaningless to me.
Right. I was just like, I don't see the distinction. I really don't.
Right. I don't either.
So we're just going to call it the same thing for the purpose of our discussion today. So that is anytime you're using technology to assist with your medical appointment.
Right.
Okay.
So for us in rural communities, the most direct use of telehealth is actually telemedicine. So I'll probably call it both, but let's just call it telemedicine.
Okay.
So remember that this can be used between provider and patient. This can be used between provider and provider, like in the sense of consultation.
Okay.
Providers,
So that'd be like you consulting with somebody on the East Coast
specialist
to help your patient.
Yeah.
Okay.
And then it can also be used with an appointment with the patient, the primary care provider, which in this case is kind of me, and then a specialist. So the three people are kind of electronically in the room.
Okay.
Yeah. So that does happen. Not very commonly, but UHS, especially Klamath and Katy Castle, are using that with a program called Maven, which I can address later if we run out of time. But
most of it, though, kind of what you've talked about with what you're doing with your physical therapy, you're seeing a specialist to help you with your ankle recovery.
I'm seeing a PhD physical therapist who lives in Portland, and that's who's going to come and talk to us next week.
Okay, is that how most of the telehealth or telemedicine is done?
No, this is new at UHS, and I've been made aware that they have it in Open Door too.
Okay.
I'm only aware of it in the Humboldt County, but anybody who has to have physical therapy knows that it's hard to get quality care in Humboldt County and virtually impossible in Del Norte County. Sutter's only taking post-operative physical therapy right now and has been for a while. And Pacific Northwest is completely overloaded.
Yeah, and it's horrid here.
It's like months. It's months. And then sometimes I have a feeling that people aren't talking to the actual physical therapist, but they're talking to a physical therapy assistant, which for the most part could be okay, but that's not what I wanted for myself. So that's not really what I want for my patients. Okay. And then the other thing, remember that telehealth also can be used to describe meetings that include continuing medical education. Like I haven't actually gone to an outside the area medical conference in a long time, but I go to medical conferences all the time. I just Zoom into them. I'm in my kitchen, listening, taking notes, baking bread, stuff like that. And then, I'm absorbing this information from higher level expertise.
Okay.
Usually from UCSF. So I go to about 2 or 3 conferences that way a year.
Okay.
And I like it a lot better.
But isn't that kind of the argument with what you just said? Isn't that the argument for going in person? Is that you're not baking bread and doing other things? You're actually paying attention to the conference because you paid to go there?
You're assuming I'm not paying attention. I am paying attention.
You're paying attention while you're making the bread, doing the other thing?
Well, I'm not paying attention when they break for 20 minutes.
Okay. Okay.
So
no. I'm just putting it out there. I agree. Some of those things I prefer to do in person.
I still get A's on the test, so I'm paying attention.
I would totally get distracted. So, but you're not me,
no,
and I'm not you. So
the only and I can write comments too. And there's a chat option so that I can really, are you sure it's that way? Because in this paper it's just the opposite.
Okay,
stuff like that.
So you have full participation.
Yeah.
Okay.
I feel like I am.
Okay.
But actual telemedicine, so the visit between provider and patient has to include both audio and visual components. So technically, the phone visits that I have occasionally at UC or at UHS are not telehealth or telemedicine, yet we still have them and we bill for them. So I don't understand that.
So you have to be on camera. So you have to turn your cameras on, both the provider
Right, you have to have
and
an
the
audio,
patient.
you have to have a visual component.
Okay.
So when I have a phone visit, it's only audio. Okay. So these distinctions are all confusing to me.
Same.
I think patients, for the most part, really like it, except in certain kinds of medicine, doesn't really work well. So it works well for some medicine and not for others. Okay. So
don't do your prostate exam by telehealth.
Yeah. How does a patient, and we'll return to that because that's an important topic, but how does a patient prepare for a visit? Well, the first thing is the patient has to give consent. And usually the medical assistants get the consent. It could be either verbal or in writing.
Okay.
And then I have to identify the patient. So usually what I do is, in the case of an adult patient, name and date of birth, but I also recognize their voice. So, and then the patient has to have the technological ability and the resources to accomplish this visit. This is a problem for certain rural populations, especially older. Let's say somebody that lived out in the Glen and didn't have great internet.
Yeah, or Hyuchi or Gasky or way up there in Smith River. Yeah. Right. Some parts of the Birch Track, you don't even get the internet.
Or if you're living in town here, but you're of a certain age and you're just not living in the technologic world, which is me. I don't have a lot of bandwidth in my house because I don't really care about that when I'm on my own time.
Okay.
So, but a patient has to have the technological ability and resources. So we were bringing elderly patients into the clinic for physical therapy appointments until the IT people got wind of it and they shut it down because apparently it's not HIPAA compliant, which is...
How is it HIPAA compliant at home but not at the doctor's office?
Because they were accessing the audiovisual through somebody's personal sign-in, who was it was a nurse, and he was also connected, to charts.
So why did not IT make a thing for patients to use that was HIPAA compliant? IT with you're not HIPAA compliant. I'm sorry, I'm going to go off on IT here because they just don't want to do a new thing.
Yeah, I would say it's too hard.
Let's pick on IT day. We're going to get hacked now. I'm not picking on all IT. I'm picking on the IT that...
I'm not. There's some great IT, but...
Absolutely.
But just because... It's interesting how they focus on a particular problem, which is really representative of a whole problem, and they only look at the part they're willing to either fix or not fix, and they don't look at the positives. Like, a lot of elders for gait stability need physical therapy.
Yeah.
And it's important, but, a lot of elders that I work with, they don't have phones. They don't care about it.
Yeah.
Maybe they have an iPad. They do 3 things on it.
And for those who are listening in IT that don't understand for gait stability, that's a matter of life and death. Right. A broken hip can cause you to die.
Right.
So having your gait stability and not falling gives you a better quality of life and prolongs your life.
But the obvious thing is once the problem's identified, what's the workaround? So in medicine, we look at that all day long.
Yeah.
If we can't do this one solution, what's the plan B? What's the second way we try and solve this problem? We don't just drop the problem and walk away. But
yeah, and most IT doesn't do that either, to be honest with you. Most IT I've worked with, they feel the same way you do. Okay, how do we implement this to be the workaround? How do we make a solution here?
Right.
So
it's okay. We're done with IT right now. So
we'll talk about telemedicine. We're going to talk about it all day.
Right. This next thing has kind of cracked me up. So demographic information is collected, including insurance information. So you always got to bill. The beginning of every encounter is like the wallet biopsy. Whatever. Expectations are set. This means that the patient and the provider need to acknowledge that not all clinical problems can be addressed this way. And oftentimes the time parameters, there's like a timer on, and the time parameters are more stringently enforced than in the clinic.
Oh, wow.
So that means there is no doorknob phenomenon. Do you guys know what that is?
I know what that is, but you're going to explain it to other people.
So what it is you know, somebody has, let's say, a 20-minute appointment, of which I get 7.5 minutes. And as you are standing up and you put your hand on the doorknob to walk out, they go, but what about my crushing chest pain? So, you know, the lead is buried and you can't walk out of the room and, or in this case, end the conversation without addressing that. And so what a patient probably should have brought up first, but for reasons known only to them, you know, brings it up at the last minute.
Yeah.
And so it makes it impossible to fully address what is probably their most important problem in the visit. So there's a timer clicking, guys. Organize. Not decide what you want to talk about, what's most important to you. And vital signs are self-reported, so the patient should have them on hand. So that means weigh yourself before the appointment. Maybe if you have your little home blood pressure cuff, do that. Maybe if you have a pulse oximeter, which is the little thing you put on your finger to tell oxygen saturation and heart rate, you know, get those informations to the provider, because there's a reason they call them vitals.
Yeah.
Okay. And with telehealth or telemedicine appointments, it's like those aren't important, but they are.
They're
oftentimes those seal the diagnosis. So.
Yeah. And so it's important to be honest about those things too, right? You can't just say on your scale that you're 10 pounds lighter because you want to be 10 pounds lighter.
Right. Exactly. So talking about what kind of visits can be done with telehealth. So when I worked at Open Door on 10th Street on the Open Door mothership in Arcata, we worked with UC Davis with a psychiatrist who was experimenting with telehealth. And this was like 20 years ago.
Okay.
And I was like, whoa. This is so sci-fi, man, very Star Trek. And and I was super impressed with it because they oftentimes had to have me in the room.
Why?
Because it was a study, I think.
Okay.
And they didn't really know how it was going to go. So counseling was very early use and was very successful. So that UC Davis psychiatrist went on to publish, and it must have been favorable because he continued to provide psychiatric services for people on 10th Street Open Door for a long time.
Okay.
And that was pretty much the only thing we had there. He wasn't really doing counseling. Psychiatrists don't really, they do med management. But,
okay.
But an example of counseling would be Better Health, which is online counseling.
Yeah. I did that when my brother was passing away for the grief counseling.
Yeah. And it's, I think, super helpful, but I also think it's a little bit funneled to getting people into the office. So the hope is that you connect with a therapist, you establish the relationship, and then you slowly transfer from online to in office.
I did not have, that was not my experience, but I liked that you could answer the little questions, pick the therapist that you want. If you're not happy with your therapist, you don't have to go and tell a person. You just click the little button and get a new therapist.
More availability.
Right. You can do it in the evening time. You can do it on the weekends. It's whatever your therapist has available. I did not bill my insurance at the time. I just paid the $60 out of pocket.
Right.
But they'll bill your insurance. I thought it was
a lot more than that now, though.
Oh, okay.
I think it's like $150 a visit.
But again, if you have insurance, they will bill your insurance, and then you just have your copays.
Right. So other kinds of visits that are suitable are medical primary care for treatment like UTIs. In 2010, the Infectious Disease Society of America developed a protocol that's applicable to the nursing profession where they can treat UTIs over the phone. And everybody in the world does it but Del Norte County. I don't know why.
Wow. We are that far behind?
Yeah. I don't know why they don't do it.
I'm wondering if that's a finance thing because we have to pay to go in to see the provider. So you get to bill like $250.
It might be, but I also think that the providers are hung up on having to have a urine dip, which is not at all the most important part of the information. What the patient, according to the Infectious Disease Society of America, the most important information you get is what the person tells you.
Wow.
And that you don't need the dip, but up here they will not let it go.
Right. My brain still, but I'm not a provider, and I shouldn't know that information. But yeah, right. I still think you have to pee in a cup if you have a urinary tract infection.
Yeah, just because your grandma told you that doesn't mean it's current. So, and I'm always like, yeah, just I don't need the urine. I don't need the dip. I don't even look at it, but the medical assistants are threatened from an inch of their lives if they don't get the urine, like calamity will ensue.
Wow.
So they don't listen to my express wish.
So that's outdated information, and we're just hung up on it.
It might be a billing point. A urine dip might be the billing point.
Right. That's what I'm thinking.
Like $25 or something.
54. I have no idea. I just made that up.
So other medical primary care that works well with telehealth is dermatology, which somebody at UCSF, a retired dermatologic professor, was working with me probably about 15 years ago, and he would get a digital picture. This is when digital cameras were kind of new, and he would get a digital picture with a clinical synopsis of relevant past medical history, or what meds were tried and failed, and what do we need to know about this person to make a diagnosis? And he was quite good at it, but he was such a dermatologist that you had to be really careful on how you gave the patient's past medical history, because he wasn't current in his acronyms.
Oh.
And so I speak in acronyms, so that was a little bit of a problem.
You speak in kindness, and he speaks in clinical terms. Got it.
Right. He used to call me P.A. Szabo. P.A. Szabo, please do not speak in acronyms. Anyway, whatever. Med management of chronic disease. So chronic pain could be it. And that actually in this format, that could be kind of a Zoom meeting with multiple people on. And then the provider can sequester people at times to have individual conversations, but they can talk together also as a support group. So that works well.
Right. So when we were talking to Melissa Nelson with Aegis, she was talking about that too, about the providers will be here on some occasions, but mostly they will be taking care of it with telehealth out of Eureka.
Right.
Okay.
Yeah. So that works really well. And then some things that are so mundane and ridiculous, like completing forms. Really? And this kind of hit me, and I added this because in acute care clinic yesterday, we saw, let's say we saw 15 people, and 4 of them were there solely because they needed doctor's blessing to go back to work.
Wow.
Which, can I just say, I think that's ridiculous. We just write down what the patient tells us. So if the employer is not believing what an employee is telling them about the amount of time off that they need, and they're going to put this barrier to return to work so they can ferret out the truth, we just write down what the patient tells us.
Having worked in HR, it has been my experience, and I know employers are going to go all up in arms about this, but working in HR, most people lie to return to work because they need the paycheck. Then people are lying to get out of work. Right. And that has been my experience here in Delaware County. You will lie and come to work on a broken leg or be in the middle of a heart attack so that you can pay your rent before you're going to lie to get out of work.
Totally.
So I
did that after I had my foot surgery. I was cleared to go back 20 hours, and I went 20 hours at each of my employers.
Instead of 20 hours total. So you worked twice as much as what the doctor cleared you for.
Well, they weren't specific in their no.
So people lie to go back to work, because that's been my experience, and it's what you did too. All right, go ahead.
Right, I get that, but they're not improving honesty by making people sit in a waiting room and then present in an exam room.
This is true, they are not.
Yeah. So I write a lot of notes. Anyway, medical specialty care is really helpful, like cardiology, which is heart specialists, endocrinology, which are people who are specialists in hormonal issues, hepatology, which is liver, nephrology, which is kidneys, neurology, which is nerves and brain, and ophthalmology, and that one surprised me, which is eyes.
That one surprises me too.
Because if you go to the eye doctor, they do a lot of hands-on exams. They look at your retinas and stuff, so they must have a way of doing that. But that surprised me. But they were really gung-ho on ophthalmology.
Ophthalmology, though, that's medical eye. So maybe they send you to the optometry first and then they review it. I don't know.
That's not what they implied. They implied that patients telling you about their clarity of vision was as accurate as what we call a visual acuity test, aka a Snellen test, which we've talked about before. The most popular poster worldwide is that little one with E's and stuff. But I personally find it hard to believe that somebody can interpret their visual acuity accurately. But whatever, they say it works. So, and then we also I got a little note to talk about Maven, which I think I did already, but Maven is a bunch of it's a program, nonprofit, with a bunch of retired physicians who were engaged at medicine at the tertiary care level and are now not really able to leave the dance, but still wanting to be involved in maybe a reducing, and they zoom in and actually into the exam room when the primary care person is there and the patient. So they're super. It's like if you had the best grandfather in the world who was guiding you through complex endocrine problems.
Nice.
They're really helpful, and they're very respectful of the relationship between the patient and the primary.
Nice.
But there are limitations, and this kind of medicine leaves out important elements of touch, physical presence, and emotional connection, which
it's huge.
Is kind of where I've hung my hat in my career. I think the hands-on physical exam by somebody who is maybe trained old school and does it completely makes me weep with the beauty of it. It's like the best symphony, or it's like...
I doubt very many people listening to this have any idea what you're talking about.
I know.
But
it's like the old-fashioned doctor has a little black bag, comes in, opens the bag, all the students are sitting around, the patient's sitting there going, I don't really know what's going on, but I'm going with it so far. And then they do a head-to-toe assessment. What they can tell from a physical exam is a thing of great beauty.
Yeah.
But we don't do those anymore.
Nope.
A lot of people don't even get exams. And they get excited if their right ear is hurting and I look at their left ear because they think they only get an option of one ear.
Yeah.
But you really always start with the side that doesn't have the problem so that you can see more when you see the side that does have the problem. So I don't think physical exam is a thing really for people anymore, which is too bad because the patients like it. They have ways of doing physical exam, like Dustin Jaco, the PA at Open Door, has like remote physical exam capabilities, and I'm like, meh, not feeling it. I think you have to really touch people. It's also hard to interpret body language. And you know how when you're talking on the phone with somebody and you say something and they say something and you don't know who's really got the floor to talk, and you lose that smoothness of communication.
And there's so much that is said in body language and tone and facial expressions that you're missing out on.
Right. And technical problems are a thing. They're a big thing. If you're like when I'm doing teen clinic over at College of the Redwoods, the bandwidth is so puny over there, and the demand is so high because the students are all using their computers at the same time that everything is really slow and sometimes just drops off. You just get dropped and then you can't get back on. And then, like I mentioned, there's a lot of people who don't have the greatest internet where they live, or don't have the equipment to use it, or don't have the knowledge to use the equipment that they do have. And, it's not like most people in their home have an IT person there.
Yeah.
So it's hard, and on a lot of people it's embarrassing, and so they don't want nothing to do with it. So it's not really known if healthcare delivery's improved with all this, although remote visits are cheaper, so that's got to be better, right? And practice patterns like the overuse of antibiotics is a problem. So if you're you've had your cold 2 days and you're certain that you need antibiotics because you have a quote unquote bronchitis or a sinus infection. It's easier for the provider who doesn't have really any information to just cave and give it to you. And I do think it could be important for rural people, but I don't like them. It's not something I ever really want to be involved in more than the extent that I'm already involved. But there's an overall movement to replace providers with AI, and this seems like the conduit to do that. And I'm not loving that.
I agree, but the AI, I don't know. I think the AI would get rid of the MAs and the nurses and those things, but not the actual provider who's going to write the prescription. Because now you're talking about the AI is going to write you a prescription.
Yeah. How do you credential somebody? How do you credential AI?
You don't.
How do you
still have to have a provider. So the provider's going to have to do more. And then the cost savings is not going to, because the insurance companies still are going to jack up the price. We're still going to be paying the same amount. It's just going to make the insurance companies more money.
Right.
So that's the cost savings is we're going to get rid of our nurses and our MAs.
Right. You don't have to pay the computer as much, but the IT people will be.
Yeah.
Yeah. They'll have.
And the providers, we're going to work them to death. This is just, I think, right, because we talk about AI. AI has a use in these things. I just don't think, I don't think the AI is ever going to replace you or a doctor or physical therapist.
I hope not, because as a patient, I'm not going to go see him. I'm not going to put up with it.
Right? And nobody's going to go and trust it. We go to Dr. Google so we can come and tell you that you're wrong.
Yeah,
I know. We're not going to get rid of that, Lynn. We don't want AI. We want to tell you you're wrong.
You want the hands-on. You want the interaction between human beings.
Yes, we will never straight up just trust the AI.
But providers are effectively muzzled when they bring this up. So, So they can't really advocate for patients or themselves. So really, if you all don't want, a computer that's your doctor, the patients are going to have to speak up.
Yeah.
So
how do the patients unionize?
What?
I said, how as patients, how do we unionize and take back our health care? That's all I want to know.
I don't know. Boy, that's interesting. We should talk about. That's a topic. How are we going to plot the revolution? I think that's really great. Revolution. I think that's really a great question. How do you unionize? Right now, mostly you get Yelp stars is kind of what you get.
So that's for the providers, right? So I'm all for the providers unionizing. I think you guys are overworked. And that's not going to happen. So what do we do for the patients? How do we unionize? And
I think the way they do it is revenge Yelp stars.
All right.
Yeah.
So just go in and give not the provider 0 stars or 1 star, but go and give Sutter or Open Door or UIHS. Just go and be like, I give you a 1.
Right.
You guys suck.
This is why you get a little podium for a minute. But that's not effective. People who curate those kind of websites just get rid of that stuff. I know that as a fact from when I was working in Humboldt County, that we just had an office manager who'd get rid of all the bad reviews. And even though they were similar and they were pointing out structural problems. But
yeah.
So I want to tell you about my next person. His name is Dr. Madison McGregor. He is a PhD physical therapist who's been working with me. My hope is that he's going to be on the program Call In from Portland, next week, although I don't think he realizes it's the Super Bowl next week, which probably means he doesn't care. But I hope so.
It's
but he's been helping me post-operatively with my knee, and he is the bomb. And he's just one of our rising stars that is really helping Del Norte. Was born and raised in Humboldt County and now living in Portland, but he's able to work with rural people in Del Norte, mostly works with UIHS in Del Norte. And he does Zoom visits. Nice. And I found him incredibly beneficial. And so we'll talk about a way that, telehealth really helped somebody who just wasn't getting the care they needed in this county, which was me. So,
well, that's good.
Yeah.
Because we like you and we want you to be able to walk around.
Well, here's my secret weapon, Dr. Madison McGregor.
Great.
Amazing.
All right. Well, thanks. I'm glad he'll be here, and we'll get him in before the sports ball starts, and so that he won't miss anything if he's interested in that kind of stuff. Thanks, Lynn. I'll see you next week.
Okay. Bye-bye.